Hello everyone and welcome back. My name is Dr. Ben Osevwe, and today we are going to talk about factitious disorder. Some people call it fictitious disorder, but the clinical term is factitious disorder. This lesson is for PMHNPs, PMHNP students, caregivers, and anyone who wants to understand this condition with compassion and clinical clarity. By the end of this video, you should be able to explain factitious disorder. We will talk about what it means, why it may happen, neurological, psychological and social root causes, treatment options, and nutrition or vitamin supports. Short disclaimer. This video is for education only. It is not medical advice, diagnosis, or treatment. Factitious disorder can involve serious safety risks, unnecessary procedures, self-harm, or harm to another person. If a child, elder, or vulnerable person is being harmed, follow mandatory reporting laws, and seek immediate professional help. If someone is unsafe or suicidal, call emergency services or 988 in the US. Now let's begin part 1. Factitious disorder is a mental health condition where a person falsely presents, exaggerates, or pretends to have symptoms. A simple way to explain it is this. It happens when a person acts sick because they have a deep psychological need to be cared for. This is different from malingering. In malingering, the person is usually trying to get an obvious external reward. They might be looking for money, drugs, time off work, or avoiding jail. But in factitious disorder, the goal is different. The main goal is not usually money. The person may be seeking care, attention, sympathy, comfort, or the patient role. Cleveland Clinic describes it as conditions where someone appears sick or makes someone else appear sick to receive care. Mayo Clinic also notes it is not the same as making up problems for winning a lawsuit or getting out of work. Let's move to part 2, what it can look like. This disorder can manifest in several ways. It can look like reporting false symptoms, exaggerating real ones, or even changing medical records. Some may tamper with lab tests or take medication specifically to create physical symptoms. Others might inject substances to cause infection or purposefully keep wounds from healing. You may see people seeking repeated surgeries or moving from hospital to hospital to avoid detection. There is also factitious disorder imposed on another, where a caregiver fabricates symptoms in another person. This often involves a child or elder. This can be abuse and requires urgent protection and reporting. The illness story may not be fully true, but the emotional suffering underneath is very real. In part 3, we look at the neurological root causes. It's complex, with no single brain cause. First, reward and care-seeking systems. The brain may learn that being sick brings safety and connection. Second, the stress response system. Trauma or fear of abandonment can activate the nervous system. Third, emotional regulation circuits. Brain areas involved in impulse control may struggle under stress. Finally, body awareness. Some become highly focused on illness signals due to past medical trauma. Moving to part 4, psychological root causes. This disorder often has very deep psychological roots. One major factor is the need for care. Some learn that illness is the safest way to receive comfort. A history of childhood abuse, neglect, abandonment, or early hospitalization can significantly increase risk. There is also identity around illness. A person may feel empty or unimportant unless they are a patient. Shame and secrecy are huge. People may deny the behavior even when faced with clear evidence. Finally, poor coping skills. They may not know how to express emotional pain or ask for support directly. In part 5, we discuss social root causes. This includes things like loneliness and poor support. Family dysfunction and unmet emotional needs are common. Healthcare access can also play a role. Even social media attention around illness can reinforce these behaviors in some individuals. For PMHNPs, the goal is always to protect safety without ever humiliating the patient. Now for part 6, treatment options. This can be difficult because the person may not admit what is happening. The first step is building a therapeutic alliance. Start with respect and focus on safety. Instead of saying, "You're lying," say, "I can see you're suffering. I want us to focus on keeping you safe." Coordinate care through one primary provider. This reduces repeated testing and unnecessary procedures. Psychotherapy is key. Approaches like CBT and DBT focus on trauma and emotional regulation. Trauma-informed and family therapy can also help the person find healthier ways to ask for care. We must also assess and treat co-occurring conditions like depression, anxiety, and PTSD. Safety planning is vital. If another person is being harmed, follow all legal protective procedures immediately. No medication specifically cures this disorder, but it may help with co-occurring mood or sleep symptoms. Part 7. Nutrition, vitamins, and supplements. Food and vitamins do not treat the disorder itself. However, nutrition supports general health. Focus on regular meals, hydration, and plenty of protein. Add fruits, vegetables, vitamin D, and B vitamins. Magnesium and iron can also be helpful if deficient. Patients should avoid unsafe supplements, detox products, or anything used to create symptoms. Nutrition should never distract from safety assessment, psychotherapy, and medical monitoring. Part 8. How to explain it simply. You can explain this to patients or families with compassion. Say, factitious disorder happens when emotional pain comes out through illness behavior. The goal is safety and support. We want to care for the person without feeding the illness behavior. Finally, Part 9. When it is an emergency. This disorder becomes urgent in specific situations. These include self-harm, induced infection, poisoning, medication misuse, or severe bleeding. Any harm to a child, elder, or dependent person is a critical emergency where safety comes first. So today we learned that factitious disorder is not simple lying and not just attention seeking. It is a serious condition where symptoms are created because of deep psychological needs. We reviewed neurological factors like the reward system, stress response, and body awareness. We discussed causes like trauma, neglect, identity around illness, and poor coping skills. We covered social factors like loneliness, family patterns, and reinforcement from care. And we reviewed treatment, building an alliance, coordinated care, and safety planning. The main message is this: factitious disorder is serious, complex, and treatable with compassion and boundaries. Again, my name is Dr. Ben Osevwe. Thank you for your commitment to understanding this condition. For support, you can text 832-991-6516. We are here to help you in your journey. Please subscribe to our YouTube channel for more educational videos like this one. And join our mentorship family today at rotationmatchnetwork.com. We'd love to have you. Thank you for watching. And remember, compassion and boundaries can work together. See you next time.